Okay, so here we go. For people who are missing us, this is our second design team meeting. We had met back at the end of last month and talked about a longer list that we had gotten from a larger group that we had surveyed for potential measures. And then we had narrowed that down based somewhat on the feedback we got on our last call, as well as tried to categorize them into broader categories. And to be honest, we only had 2 responses to the survey, so maybe it was the wrong way to try to get feedback, but either way, we won't go through it because I don't think probably the results are too useful today. Instead, I have the list of those variables or the shared measures that I was hoping we could run through and then see if there are any that people agree at this point just need to be crossed off the list because they're just so far out there and never going to meet any of our criteria, or if they're okay enough to keep in. And as we go through them, I know Paul had asked me for sources of the information, and so Bree and I had talked a little bit about the sources, so I tried to add, I'm going to share this list with you. I tried to add the sources to this document, so as we go through it, we can see the sources, but also then I'll just keep some notes, because if there are some questions we have that may change whether they are in or out or not considered for their next webinar in June with the full group, then we can go back to these data sources and get more information as needed. But our goal is to really continue to work on this list so that we are prepared for June 19th when we share the list with our broader stakeholder group, as well as ask them to take the list then into their local communities and get us feedback so that when we come together in September, we'll be able to make those selections. I would also add that we've had some internal conversations about the process to use in our September meeting, and we're hoping to create a second little sort of design teamwork group that will meet between June and September to really hammer through what the decision-making process at that meeting will look like, and so that is clear. So we'll be asking folks if they want to participate in that between meeting activity as well, and that's certainly something you guys are more than welcome to be a part of. But we realized, based on some feedback we got from our first even design team meeting, that deciding what the final 10 are, we're going to need some structure around that decision-making process and making sure that everyone understands it so that we get a good outcome. Bree or Deb, did I miss anything that you want to jump in and add at this moment?
No, I think you got it from my end.
Okay. All right. Okay. So I am just then going to start through my list here.
Sarah, do you want to, before you go one by one, do you want to just, can you do sort of an, we grouped them, right? And so, yeah. So do you want to just sort of orient people on the list?
You bet.
Do we all have a copy of this, or is this just on your?
I just did it, and then I was going to write notes and send it out, and then.
Yeah, so maybe just orient people about the universe of what we're about to go through, and then we can go through it. How about that?
Perfect, you bet. And this mirrors if you had clicked on the Survey Monkey link and looked at that survey and decided you weren't going to do it or did do it. These are the shared measures that we had included after the first design team, and we asked people to rank them to say, did they meet the criteria? Did they not meet the criteria? And if you'll recall, we did review those criteria on the last meeting, and then we had included them on that survey again. So I don't have them in front of me, but I can certainly grab them if there's a question about them again. So our first overarching group was basically, we put in women's health, pregnancy, newborn. We seem to have a cluster of measures that focused on that. Basically pregnancy or pre-pregnancy to just being born. So those included, we'll go through the specifics after. The second we really did by infant to kindergarten. So sort of a lifespan view. if you're following me. So we have the woman's health, reproductive health, or reproductive period to baby being born. Then infants to kindergarten, measures from that period of early childhood. Then we had kindergarten to third grade, where we had several suggested measures, which you'll see. And then after that, we had groupings of physical health for all children, measures that fell into that. Social determinants of health, sort of those broader measures rather than just maybe direct health related measures. And then risk factors. So those were our
Sarah froze. Sarah froze. She was having.
and as we go
There she's
forward,
back. Okay.
go ahead.
Oh, you just froze for a minute.
Oh, my back.
You're back.
Okay. Okay.
Blame it on the thunderstorm.
That's right.
Goodbye. Just kidding. I hear lightning. Just kidding. All right. So those we started, like, as I said, like lifespan ones, and then we went to the broad overall physical health, social determinants of health, and then risk factors. And if people ultimately say, I see a better way, like you guys should have done it this way, we're welcome to feedback on that as well. Go ahead.
Is the plan to get the feedback in this discussion, or via email, or what? First of all, I want to say I'm really sorry that I have not been more actively involved, because this is something we're really very, very invested in, and I have a lot of ideas, and I hope I can make up for lost time in giving feedback about some of this stuff. But
Yes, now it's good.
but in the social determinants of health area, I think there's, and you folks probably know this better than I do, but the things that, you can measure all these outcomes of well-being or lack of well-being, or in health and such. And since, your focus is on mothers and children, all of these things are really appropriate. But there's a lot of evidence that these outcomes are directly related to poverty, to education, to stress, racism, a lot of things which sometimes can be measured easily and sometimes in a more difficult way. But I think that if the goal is to really have an impact on the outcomes of health for mothers and children, it necessarily has to address those issues, and those issues are hard to address. I mean, embedded racism, clearly in the Indian nation, there's collapse of cultural stability that's happened over hundreds of years, and lots and lots of factors. Stress is actually one of the real big ones, really big factors in poverty. So one of the things I can do, if it'd be helpful, is to provide a set of social determinants. There are different lists. The Robert Woods Johnson Foundation has some with the World Health Organization. So some of these lists are pretty long, but I think the key ones have to do with education, poverty, stress, which all seem to be interrelated. So I wonder, how I could be of most help at this point.
Right. I mean, I think at this point, if there are, I think a generic list of everyone's possible social determinants of health is probably broader than we're looking for. But if there are specific ones that Montana has data on that is available and collected and accessible and sort of meets some of those criteria, I think we'd love to have those as part of the list for the large group to consider.
Okay.
Do you have other thoughts?
So we also, Gary, developed a set of criteria that we are trying to run data points through that I think if you track back in the communications we've sent out. So I think that in addition to what Sarah's suggesting as far as running a filter around the purview of the age, the domains that we're looking at around moms, newborns coming into school, if there's a look at our criteria as well, I think we'll potentially hone it a little more, and then I think that we'd want to get those into the hopper pretty quickly here.
Okay, so before I send you something, then I'll make sure that that criterion is central to what I send, and I think the idea is you can start with a very high level social determinant of health, and then they're nested underneath it could be a whole bunch of subtopics. So if you'd like, I can send both the overall topic and the subtopics, but it could be condensed down to the high level topic if you need more simplicity.
Sort of the intention of this is and it's an open question, right? I mean, can local community practitioners and state program leaders agree on 10 measures, potentially 5 positive and 5 about risk or gap, that would allow us to then start doing better coordination and collaboration. So keeping that in mind, I mean, that's our big challenge, right? Is that there's this sort of limitless amount of data that we all swim in, and some of it's actionable and helpful to our purposes, and some of it's not. And so just, keeping in mind the integrity of the project as you sift through would be another filter to look at as you look at what you have access to.
Right.
Okay.
I always try to keep in mind, like, this project sort of came out of our work with the local early childhood coalitions and Deb's training on collective impact and the need for shared measures and their desire to be able to, as a local coalition, pick one of these measures and show that they can move it. So I think it needs to be something that a local coalition can feel like they could make a difference in, more than like poverty. Poverty's a hard one, I think, probably for them to feel like.
Could one of the things, even though these are hard problems to solve and sometimes they take many years to address, could part of this be woven into what you're trying to do, that those workers in the coalition, when they're meeting with the people in the community, that they actually can sort of track or inquire about certain things which are related to the social determinants of health? Because it's one thing to say, how you feeling, what's your baby's birth weight, blah, blah, blah. But it's another thing, while you have that great opportunity and your team has an opportunity to interact with real mothers and babies, that might be an opportunity to collect some information about stress, poverty, education, other things like that, and which at least could provide you a baseline to provide for policy support later on. Now that may be out of scope with what you're doing, but it's really a question rather than a statement, whether you see your coalition members taking part in such a thing of trying to understand some of the deeper issues related to health, because again, I think there's a lot of evidence that health is an outcome of these factors. So measuring health in itself gives you some insight into the health, but measuring the social determinants of health gives you some insight into why people have the health outcome they have.
And I think that's a question probably we could pose to the coalitions, particularly in the strategic planning part. If it's data we don't collect but want to, do they feel like that's something they want to try to collect? I mean, I know just from experience with a recent grant where they're trying to do universal trauma screening, it's been a major sort of uphill battle to get communities to add additional questions like that. So I would feel like that's a better question for local coalitions and their members.
Mm-hmm.
So, Sarah, do we have anyone from a local coalition on the phone right now to kind of weigh in on the participation so far?
No, we don't have Kristen on today. She's the only one who jumped on our design team. But I think that would be a fair question for our June meeting as well, just to.
Well, how about if we redirect back to Sarah stepping through these data points, which I think will continue to help us all be thinking about these good questions and see if there's some, other high-level feedback, like how Gary's thinking about this, as well as just sort of, the tangibles. How does that sound for the next step in the call? Great, thanks.
Okay, so let's go through this group. This first group will go by group, and then if you have a comment on any of them or many of them, we can go into detail. But the women's health, pregnancy, I don't have my screen up, so I can't see who just joined us, but welcome.
And Sarah, again, is part of the intent of this process right now to be somewhat how we were trying to get feedback on the online survey, which is so someone might say, of those 4, I really like these 2, we should not worry about these other ones, or these are all awful, or are you looking for that kind of feedback from folks today?
Yes, if you think it doesn't meet any of the criteria and it's crazy and it needs to get off the list before June, absolutely. If you think it has to stay on the list and it's the best ever and it's super important, yes. If you don't really care either way, I guess then we'll just assume your silence is fine.
And just so I pulled it up, just so we have it. So the criteria is impact on children, so aligns with the purpose of the project, outcome focused, includes both risk and protective or hope measures, includes domains of family well-being. That's the first one. Second, accessible, easy to collect, already collecting, or able to monitor. Third is actionable, relevant to urban and rural communities. Community coalitions can affect it. Number 4 is high quality. Valid sources can be used to establish a baseline, replicable, as in we can follow over time. And 5, meaningful. Family is always defined by the family, cultural relevance, etc.
All right. So under women's health, pregnancy, and newborn data, there was a suggestion that came from from Jeff and Bob, who were not able to join us, that we include a measure from the Behavioral Risk Factor Surveillance Survey, the BRFIS, and that would be the number of women ages 21 to 65 who've had a Pap test within 3 years. This had been in the list of their hope measures. We'd also had one that was the number of Montana hospitals designated baby friendly. And this is a program that comes out of the Nutrition and Physical Activity program at DPHHS. So it would literally just be working with them to continue to get the number that have been certified as baby friendly, and perhaps include a number of those working towards it, but real low tech on that one. Number 3 on that domain was percentage of low birth weight babies. And then the final one was a postpartum visit within 60 days of birth. And you can see that number 3 is a kids count data point. So we would just propose to use the same sources, not reinvent that wheel. And then the postpartum visit within 60 days of birth, when we had met with Blue Cross, they had indicated that would be a data point that would be easy. And so we were hoping that we would get that through Medicaid or insurance claim data. So I'd open it up to comments or suggestions on those.
Can I ask a question? There, I see a static image that goes from 1 to 10, and previously you actually had a kind of live document that you were sharing. Is this what we should be seeing right now? The static document that should, on the screen share? Now it could be just something that's happening with my screen too.
Can you type into that? I think before it looked like it was bigger on our screen, Sarah.
Yeah, you'd shown that list, and then you showed actually a live document. you were sharing on the screen?
It probably looked live because Sarah was moving through it. It's
Gotcha.
whatever Sarah does that we see.
Oh, okay. I see. Okay, I see someone moving their mouse. Alrighty.
And actually, this is Tala with Kids Count. I just wanted to comment on the source for the percentage of births that are low birth weight. That is from Vital Statistics. So we didn't just make it up.
I have a question. So this might be a question for Bree. How much is the baby-friendly designation a proxy for some assumptions around hospitals, you know, doing something that really makes it a better, safer, more awesome birth experience or what have you? I mean, because that seems like a really tangible one to me that would be a proxy for, but it won't, only if it's kind of a legit proxy and not something that, you know, hospitals can really run the gamut from, you know, check the box for that to we're really.
Yeah, good question. No, it's a very prestigious designation that takes several, I think St. Pete's, that was a 5-year process that takes site visits from the designated agency and new policies and all sorts of great stuff.
And is it something that the local community coalition could put pressure on or partner with the local hospital to do? And would it gather people around that process and ensure that, you know, moms are better served? Or
no, step number 10 of baby-friendly designation is connection to community resources. So I believe there's a lot of opportunity in that. I don't know necessarily that hospitals are doing that as well as they probably could in their plan. But it's certainly something that a community could put pressure on their hospital to do. It really does increase breastfeeding rates and promote attachment, et cetera, et cetera.
Bree, I'm curious, on that designation, baby friendly.
Yeah.
Having now had 4 kids, and you know, we had a midwife and once, and Kaiser, and this and that, and it seemed like some places were much better and much more in tune with a mother and had greater skills that sometimes are associated with midwifery, like, you know, turning babies and all that. And in some of the hospital settings, they seem to be really it was like a automated process factory or something. Does that baby-friendly designation, does that sort of consider all those things in terms of the options for the mother in giving birth
Here, let me just show you something. Doesn't necessarily talk about like the type of care provided per se, but it does. Can I share my screen, Sarah? Oh, I can't. Okay, I'm just going to talk about them then. Okay, so it really is just all about, like, you don't have formula on the floor. There's policies. All the healthcare staff has to be trained in the skills necessary to implement the policy. Moms get skin to skin right away. Breastfeeding has to be started within 1 hour. You don't give pacifiers without permission. I mean, all families are encouraged to room in, all sorts of those kinds of things. And so it does require kind of what we see as this big organization around this early care from the beginning. It is actionable, and it certainly, you know, breastfeeding is certainly foundational for health outcomes should a mom want to do that.
Okay.
I would advocate, unless someone disagrees, that we keep it in for the June meeting, and when we allow folks to ask questions on other ones. How's that sound? And if anyone hasn't spoken yet, you know, if you want to add in something right now, that would be lovely.
This is Tala. I'd like to add that it would be helpful for this indicator if you could link it to breastfeeding rates, because the way it's stated in in the matrix, that's not obvious that it's a proxy for breastfeeding rates, because from what I saw it as more of a luxury problem. Let's get women and babies to the hospital in a healthy condition before we worry about the nature of the hospital. But if you can conclusively link it to breastfeeding, then it becomes a whole different animal.
Great, that's helpful. How about the other three measures that we have in the women's health, pregnancy, and newborn data? Any thoughts on if some of them feel weaker to either have impact or be actionable, or stronger?
I see a problem with the postpartum visits within 60 days of birth because it only applies to a subset of the population.
Why?
Because, well, I guess could you conclusively get insurance claims?
Well, we have a meeting we've had a meeting with Blue Cross, and they said they could do that for us.
What if you're not insured with Blue Cross?
Well, there's specific source. We'll have to continue to investigate that, but they're the
Yeah. It's excellent in that it's the only one here that addresses mental health issues to a certain degree. But I would just be concerned that it leaves a large portion out.
In that, I guess it would be number 3. Is there any consideration of tracking also the kids that are born addicted? I was at a meeting with some tribal elders, and they said that one of the nations, something like 60% of all newborns are born addicted to some substance. I think it was methamphetamines and such.
The data on that comes from the birth certificates that are submitted, and so any kind of addiction data information is not included on the birth certificate, so that would have to come from a different source, if at all.
Would it be relevant to the work you're doing to try to track that?
I think it would be too narrow.
Okay.
How about that first one? We had to laugh about thinking that pap smears were hope measures, but aside from that, any comments that people have? And again, if someone hasn't spoken, just to get your voice in the room, that would be helpful too.
Is there a Healthy People 2020 or other kind of benchmark for that?
Sarah, are you still able to populate this? I wonder if it froze again. Oh, there you are. So for number 1.
Oh, I was on mute. I don't know why I was on mute.
I think
What do you want me to put? Sorry, I'm talking to myself.
I think Tal was thinking that in the first one, that might be something that we'd want to see if there's a national benchmark with Healthy 2020.
And I imagine if there are national benchmarks for a lot of these, that would be helpful to include.
Mm-hmm.
Mm-hmm.
And the idea behind this one was that, besides pregnancy, a woman getting these screens, this is a chance to connect her with all sorts of other resources.
Right.
Ideally, so.
And it's been collected for a long time.
Mm-hmm.
So how about if we shift to the infants conversation for now? If I'm not hearing that anyone thinks any of these are really off the mark, but that it would be helpful to have a little bit more information. Is that a fair summary so far?
There's one more that I wanted to bring up. So the student we worked with, Steph from the University of Montana, she has one. Dala, you might be able to help with this one. It's called the Copla index. This measures the adequacy of prenatal care.
Yeah, that's super complicated. The Caudal index. Babies are assigned that at birth, and we used to have data. Well, there's still data on that. We used to publish data on that, but unless you have a really detailed knowledge of how that is computed, it is absolutely useless. it takes into consideration, excuse me, like the nature of the prenatal care, the extent of the prenatal care, but all of that is dependent on when prenatal care started. So it's like, it's a maximum amount, a percentage of the maximum amount of care, maternal, under maternal, what am I saying, prenatal health. It's a factor of the maximum possible visits that are possible to have starting at wherever in the 9-month gestation period that the mother started receiving care. So it could be almost 100%, but if the mother didn't start prenatal care until the 8th month, then it doesn't account for the fact that in the first 7 months there was nothing.
Okay.
So see, it's, I mean, I can't even explain it coherently. It's, yeah, it's complex.
Okay. So the only way to measure the adequacy of prenatal care is just the first, when the care was initiated, date of first prenatal care in the trimesters.
The vital stats, they do compute a rate of adequate, what they call adequate prenatal care.
Do you think that falls in the criterion as something we can add? I didn't know if there was a good one.
It's a good one, but it doesn't take into effect that there are many reasons why prenatal care isn't adequate, and you can see that in rural counties and on reservations that it's lower because access to health care is lower. So it's not so much less of willingness to initiate care or interest in the issue, for lack of a better term, but it's because they just can't. And so in terms of getting their prenatal care, it tends to concentrate in the later months when mothers think that it matters more.
Mm-hmm.
So I don't know, it's so multifaceted that I don't know how helpful it is.
Well,
and I think it figures in with the low birth weight, because low birth weight is sometimes, or it's related to prenatal care. So if the percentage of children that are born at low birth weight is high, then it's also likely that prenatal care is poor.
I'm leaning to yes. Is there any other kind of people on the call that have an opinion on adding that to bring to the full group? Because local work can break down barriers. I see how that could be actionable.
Do we want to add that in there for now and just so it's a placeholder so we don't lose track of it?
Unless there's any people that feel like we shouldn't, I think we should.
I think it would be redundant when the low birth weight babies. So one of the two, I think, would be sufficient because they will move together.
You think that the one you're just talking about is more actionable than the low birth weight? The low birth weight, I don't know, seems hard to. I'm not a practitioner in this, but it seems like a harder one to get my head around how you would do what you would do with that.
Yeah, it's less direct. I think prenatal care has more obvious barriers, whereas low birth weight, there's so many medical conditions too. So I think, yeah, like if you want to put that in, I think you should ditch the low birth weight.
So Sarah, would you want to put a comment in that number 3 that says something about considering this other measure?
Sure, Deb, I didn't hear you. Consider what? Consider use of what?
Vital statistics, adequate prenatal care.
Okay. Okay. All right. So Deb, you want to keep walking us through them, or you want to?
Oh, I think you do a beautiful job walking. I just nudge you.
I like nudging. We're already at 40
Let's
minutes.
go to infants.
Kindergarten. So on number 5, this is just a big broad category, and if we were to say keep it in, our proposal would be that we would have Caitlin from the MSU Early Childhood Project give us the specific information that they have for our June 19th webinar, because it sounds like they have numerous data sources, including, you know, all the licensed providers, their background and experience, some of the STARS QRS trainings for providers, and they also have wage and turnover data. So
of all those, I think the turnover rate would be very interesting because it reflects so many other aspects of being a caregiver. So rather than including so many of these other factors, having like turnover rate is as a measure of job satisfaction, which would relate to job stress and training and wages, all that together.
sure. And I guess I stopped before I went through all the measures for these infants to kindergarten. The other ones would be childcare slots versus eligible children. This came from an Early Childhood Services Bureau survey that they did through the University of Montana. So it may take some follow-up on our part to see if that's something they plan to replicate or that they have available on a regular basis, if people feel like we should try to follow up on that. Number 7 would just be the number of children in STARS childcare programs. So those are their quality rating improvement service sort of measures that some childcare facilities have. And then lastly, in that age group sort of category would be the percentage of 4-year-olds that attend preschool or Head Start. The data would have to be obtained from DPHHS and OPI, and we would just use whatever data they're using for their current preschool development block grant and related programs. So there's that next subcategory.
Would that be considered a hope measure?
Number 8.
We're looking for those hope measures.
I guess we could call that a hope measure.
And actually, the American Community Survey from the Census Bureau does compute estimates of 3- and 4-year-olds that are attending preschool or not. So then that would eliminate the need to compute any kind of eligibility percentages ourselves.
So that's the American Community Survey?
American Community Survey. And then using like multi-years, they have data at the county level and by race.
Okay. Anyone, any big thoughts about missing ones we should
Well,
throw?
I know that like number 6, the number of slots versus eligible, I know that in my work with the local coalitions around collective impact, this one has come up a lot. Like, can we put a number on the gap between what we need and what we have so that we could get really tangible if we want to on a specific local campaign to close that gap? And that has been hard to find. But people have sort of felt convinced that it would be a modest enough number in the big picture that you could put some monetary value on that or some strategy around that and really take a whack at it. But what has been hard to get out the gate on it is having that number. So this might be one of those that and the coalitions will have to weigh in on this, where they might say, you know, we don't have this data right now, but if we did, we could be that much, it would really help us hone in our strategies. And so let's have that be one of the 10, and let's figure out, you know, whether it's working with the University of Montana's data or what have you, let's figure out a way to do that so that we can start targeting that more intentionally.
And it has been done on a one-shot basis. So it's definitely possible. It would be ballpark estimation, obviously, but it can be done.
Exactly, exactly. And so if, you know, if one of the outcomes of this process this year is that we get enough players at different parts of the system to say, yes, this is one of the ones we want to track and this is what we'll do to help figure it out, that would be progress forward for the state.
Yeah, I don't know. I know that it's been done. We've actually, our office has done it at the state level. I'm not so sure at the county level because ballpark estimates kind of get out of whack at the county level.
Right.
But at least at the state level, it can certainly be done.
Yeah, and I think to have it be relevant to this work, it would have to be a local data point. So figuring what's our best ability, what's the best ability to do something close enough that would allow people to get a target and start moving on it. So again, folks who've not spoken yet, when you look at these different data points for infants, any comments, any observations? I had the sudden image that people are doing like their aerobic classes while they're listening to the thing. Oh my God, I would have to like mute things and turn off my video. All right.
All right, then moving on to the kindergarten to third grade, there's only 2 measures that we had gotten, and one was kindergarten readiness, and that would be just using the measures that are available, like we had talked about from OPI and or DPHHS from current grants, although I know, to be frank, this has been a challenge even in the current grants, so my own feeling is this might be a challenging one. And the second one would be third grade reading proficiency rates, which seems much easier to gather.
And the third grade reading proficiency is already being used as a proxy for readiness, since the readiness is so hard to get.
So again, I mean, one of the things that we've been kicking around in some of the local work around the readiness is, and I don't really know how to think about this, so it'd be helpful to get other people's brains on it. But my experience is that by and large, most communities, I would even say most of them, most schools have some way that they determine which kids are kindergarten ready. And it gets defined differently, and probably the least political but most wordy way to say that is, you know, they're kids who are not in need of additional interventions when they come into the school building, you know. So I don't know what this would look like and what our capacity to do much with it would be, but if there was a way for us to allow for the local differentiation of self-definition of kindergarten readiness, but still have schools or communities, coalitions put a marker on, this is where our community is as defined by our community, and we are willing to try to move that dial and be less worried about how it all adds up for a statewide picture, but put pressure on ourselves to, with the communities that have the capacity, the will to make a marker at that's one of the things that we're interested in seeing. And
that's a great idea.
It's up right now, but the data point could be something like, you know, the number of communities that have publicly identified and committed to trying to move their kindergarten readiness marker by some percent or something, so that we'd say, you know, when we first started off, 30 communities said they were willing to share that number and start doing something about it. 5 years down the road, 50 communities are, and another 5 years down the road, the state has created a statewide kindergarten readiness measure that, you know, we now can land on, but we haven't been sitting in that 10-year period not knowing what to do about this measure because it's so tangible and it so organizes institutions at the local level around something together.
Deb, do you know who the steward of that data would be? You say that schools collect it individually.
They do.
Where does it go?
So in the bigger districts, they have a data person, right? In the smaller districts, they can kind of back of the envelope tell you how many kids come into their school district and how many need support and how many of the kids who need support came from some sort of a daycare or preschool and how many didn't. I mean, they know that information. And
yeah, but you would have to call each district then and ask them.
so that's the question, right? It's like,
Yeah.
how much does this project feel it has the will or the capacity to track this or to gather it, or, you know, so I think that's the open question. So that's what I'm suggesting, that maybe the data point is more about number of communities that publicly track it, share it, and do something about it, as opposed to what the actual data is.
Yeah, I think that's a great alternative.
I wonder if you might also want to just keep track of the birth date, because you know, just my experience in school is some kids are, you know, they get into the school system at an earlier age, or they're older, just based on their birth date and the school cycle. And I wondered if that might be a data point that would be worth looking at, in terms of, you know, like, especially for a little kid where they're maturing very rapidly, they're changing, you know, mentally changing very rapidly, in a matter of months could make a big difference.
So, Gary, this is Bree. Some of the conversations we've heard around that same topic is it's less about school readiness, the child being school ready, and it's now more about the school being ready for all children that will be entering kindergarten. And so it's an infrastructure problem instead, and because childcare is so expensive and families are having to make the decision of sometimes it's more of a financial decision than a developmental decision. That's forcing the schools and the preschool to K transitions to just be a lot more thoughtful about how that happens well, and what we can do to get kids kind of more up to speed earlier, because parents are sending at 5 just because it's an affordability issue in some cases.
But is there a mandate, as far as the school's concerned, that if you're a certain age, that you're supposed to be in kindergarten? Because it seems like there's an age range that would differentiate.
What is it? By September 1st or 30th, the kid has to be 5.
Mm-hmm.
Forget it, and then they can enroll. And then it's illegal to not enroll your kid at age 7, I believe.
Okay, so there's a lot of leeway. I just wondered for those 5-year-olds, they're 5 years olds that you know, might turn 5 on September 1st, and they're 5-year-old that might turn 5, you know, way earlier in the year.
It's substantial, especially depending on their pre-K exposure for getting ready to go into a classroom setting.
Yeah, and this is more, you know, a question than a comment. I just wonder if it's a relevant thing.
Yeah, totally. It's a real issue.
Okay, so moving along, since we're already an hour in, I think we've got that feedback, and I think we can do some follow-up and get some further information before our June meeting for everyone. So physical health, we have 3 different potential measures. So one that had come up as a hope measure was the number of children with medical homes. The second was the immunization rates, usually using the HEDIS measure, which includes one-time immunizations by age 2, and then the EPSDT rate. So people's thoughts on that. I don't know if you're still out there, Erica, or if you have Medicaid thoughts on those. Or anyone else?
Well, of course I have input. Again, it would only cover a subset of the children, because it's only Medicaid that has that program.
Yeah, this is Erica. I just figured out how to unmute myself. I would agree with you. It's only the Medicaid covered kids.
Well, now we can't understand you. You're off mute, but it was muffled.
Oh, because I have a cold. I agree with previous comment.
It's only Medicaid?
Correct.
JP, I see you out there from Blue Cross. Do you have any input on this one?
So to unmute, you hover over your screen and then there's a little button at the top corner.
Oh my Lord, I was talking the entire time. I wasn't sure whether or not you were referring to Dr. Pujol or myself, seeing we're both JP.
Oh,
No wonder none of you guys
Sarah,
were,
that's in the wrong
like,
place.
no one's answering my question, and I didn't realize I have to unmute. With that said, no, I don't have any other input. I did have some thoughts in the beginning, but I believe it was Gary who had addressed something there, so. Yeah.
And Sarah, that comment you typed, it needs to go on number 13.
Oh, okay. Thank you.
So do we have, are we emerging with some sort of thinking around this project that if the data can only be available through Medicaid, it's not a robust enough reflection of the status of kids in the state? Or is that too broad of a statement that in some cases the Medicaid data is a really reflective measure of what we're trying to do here? Because that has, just in this one, it's like, well, it's only Medicaid, so does that mean it's less less compelling for us, or does it matter from data point to data point if that's the only source or not?
To me, it's not valid as a representation for all the kids in the state. It's only a small subset. If we were looking at kids on public health insurance, it would be different, obviously, but we're looking at all of them.
I think that's probably true, Deb. I think just limiting it to Medicaid probably makes it less desirable to include.
I'm thinking about the medical home option in a similar way, Deb, as you described the K readiness. Because medical homes hold such promise to good care coordination, and the trend of pediatric medical homes is potentially moving slower than maybe that could be a assumption, than the adult or family medical homes. That could be another area that we look for progress in. I thought I'd throw it out there for discussion.
Yeah, and actually there is another source for medical home data. It's the National Survey of Children's Health. The only problem is it's not conducted at regular intervals. So if we could live with that, there would be a statistically sound data source in that for medical home.
I missed what you said that data source is. Can you tell me again?
National Survey of Children's Health.
Okay.
And how often does that come out, and how granular does the data get for a state?
It's state level. It's maybe every other year, maybe every 3 years. It depends on when they have the funding.
Okay, and it's state level data?
Yes, unfortunately. It's hitched onto a different phone survey.
So then, putting our coalition hats on, what role could a coalition play in increasing the number of children who have a medical home?
Is that your question?
Yes, it is.
Okay. I think that probably depends on who's at the table for the local coalition, but it would be harder.
Right.
Mm-hmm. Yeah, I think that would be something interesting to discuss with coalition coordinators and see what they think. Kind of another one. Do they believe that would kind of act as a hub for their community, their pediatric patients, or not?
So just as a reminder of process is that we have the whole team comes together in June, and then the work of the coalitions through September is to take what we do in June and run it through their local coalitions. Is that correct?
Yes. And then like we talked about at the beginning, we'll have that other smaller group that wants to meet between June and September to come up with a process. So as they get that local coalition feedback, they can use that to sort of finalize the measures and the within the process we'll use.
Yeah. Any other thoughts on the physical health measures that we have right here? Do they feel on the mark enough or weak, or would we want to be thinking about something else? JP, if you're trying to talk,
Yep.
still...
I was going to say, Dr. Pujol is trying to figure out his unmute button too. Let me see what he's trying to do here. He's trying to get unmuted.
Where there's a little blue box on the corner, and that'll drop down and you can unmute.
Let me see if I can jabber him over.
Also, if you put it over your face, it should show up in the top right-hand corner of your face picture. You should say mute or unmute. It should pop right up.
Dr. Pujol has a very sort of, abstract image, which I think is...
I think it's his computer. It has to be slightly open for it to work, so it's kind of a workaround. His camera's facing the bottom part of his laptop. There's his hand. Dr. Pujol, it's on the upper right-hand corner. It's like an unmute icon, or as long as you hover around that, you should get it. Oh, he's saying it's not there for him.
Uh-oh.
So if he hovers over his image, he sees a blue box in the upper right-hand corner, and he should be able to click on that, and it would be able to unmute him, I think, is how that works.
Let me see if I can.
And Sarah, can you, as the administrator, unmute someone?
Strangely enough, he's the only one who that doesn't show up on my screen for. So maybe that's why it's not, maybe he didn't join.
Oh.
Audio. He might want to hop off and hop back on.
Oh.
Or we can
He's
chat.
type. He's trying to type up his comment here and see if I can read it out loud. Oh, nope. He's still having trouble. You may want to jump off, Dr. Pujol, and back on. I guess we can continue for the time being until he figures it out.
Right, I think he probably has to rejoin because I don't see that.
Oh, there he goes. Okay, he's trying. I think we can continue. He's going to try to jump back on.
Great. There's always a call-in option too if the computer's not working well.
Okay.
So our next big broad category is social determinants of health, and in the interest of moving along, since I know we're already at 4:05. 14 was a very, very broad one, and so there's a question mark as to the sources, although I think, it's obviously a great thought. I don't know how it would be collected. It was basically proposed that we somehow measure families who receive family support services. Someone had said people who were getting home visits, but then someone had said broader. So there's room in that one, I think, for discussion. 15 was the number of counties with early childhood or best beginning coalitions. This was one we had seen on another state's dashboard. Then number 16, Gary could speak to, and I know Kristen, when she was on our last call, had talked about using this GIS data in particular to see if children have access to parks or outdoor spaces to play. Number 17 is something we'd have to ask Jeff Linkenbach to speak more to, but he has a survey that collects social norms information about positive social norms related to parenting. So those are our current list on social determinants of health.
And like I said, I will send to the group some social specific metrics based on the constraints that you've got for the project.
Okay.
Thanks, Gary.
Is it best to send it via email or just post it on the Office 365 site?
Either works.
Okay.
I wonder with number 14, I'm thinking back again to some of the work that I did around data with the local groups. one of the measures that we could get from county health was around gap between available supportive services and the pickup of the families using the supportive services. And so, you know, WIC, home visiting, like there were services that the county had available, and there was a gap between how many families use the services versus how many. And so one of the first things we started talking about was, like, how do we close that gap? How do we fill those slots or what have you? So I wonder if that would be a way. I guess I'm wearing my coalition hat today. But, you know, if a community can get a handle on that, you know, are there obvious supportive services that tie into this project? And again, my only thing I can think, you know, home visiting, but where a community could say, you know, the county knows, you know, whether they pull that out and make it actionable for a local community or not. So I guess the question would be, can we roll that? Is that one we could roll around, you know, filling the gap of take up on existing services as an initial measure of families getting services, which is not about gap in availability of services, it's about gap in take up.
Deborah, I wonder on that point if it's in scope to think about how to communicate the services through like a web portal, because there's so many services that are available to people, and oftentimes they have no idea that they exist or how to access them. And I know your local groups are doing outreach, but you know, would it make sense to actually organize all those resources that are available to mothers and their children, and then provide you know, a website that would make it real easy to access and to find out ways, you know, perhaps something that's designed to work more with your smartphone than just a regular computer. So you could, if you had a particular need, you might be able to type in that need and then find if there's a resource available in the community to fill that need.
Yeah, so how I would connect the dots on that, and then I'd love to hear Bree's thoughts, because I know that Healthy Mothers, Healthy Babies has done some good work recently on resource guides, is it seems to me that a lot of the local coalition work is about what you just described, like how do we have a central portal? How do we make sure people know about services? And that's just kind of a little bit of just the bread and butter of what they do, because by nature they're a coalition or a gathering of service providers, right? But there's not a number. There's not something they can say, you know, this is the gap and we're making progress on it, or we're doing worse. And so it's not something that they can claim success on. And so, like, some of the work that Bree was involved with here in Lewis and Clark County around home visiting was that there were, you know, for a while there were, you know, empty slots. And so they were able to tighten that up. But the story that was being able to be told then by the community and the providers was more compelling, because they actually had numbers of slots that were empty and now they're full, and they could celebrate that and maybe pivot to how do we create more slots, because we've proven that if we fill them, you know what I mean? So I would ask Bree to comment on that, but I think that's what we're trying to do, is just pull it out of business as usual and get it to something they can measure, celebrate, alert, organize.
Mm-hmm. Yeah, I mean, I think I would agree, and it is actionable, but it's not necessarily collected in all communities, so it might not fit in our criteria, but it could be something that we continue to consider. There's a couple areas that coalitions are thinking about. There's this system called 211, where it is kind of that catch-all, Gary, that you mentioned, but not a lot of communities have committed to populating that site. And then there's this online referral system called Connect that a lot of families or a lot of communities are using to take the responsibility off of a family to make to connect with a resource. And there is data that's available out of that. I just don't know if it fits within the criteria of our project, but it is a really compelling way to measure success.
Mm-hmm.
And there are communities doing that. I mean, the whole entire Healthy Families program, the home visiting program at Lewis and Clark County, they base their whole performance metric for a year on increasing referral sources. So that's available in Lewis and Clark County, but not necessarily everywhere else.
Mm-hmm.
Well, does the state gather the data, or just to use WIC as an example, like, I can't think of a specific thing, but like, does the state gather up the available slots and actual use slots? So they roll that up from counties so that there is a number there that reflects
Yes.
or usage rate?
Yes, that is available.
Take that on as a number that, we're at 76% of usage and we want to get it to 80%, and then we can break it down by county and organize by county around bringing that up. Is that?
Yes.
So that would be a way to go at it, would be to get the state reported out.
Yeah, all their funding, it's a need-based funding stream, and so that would be important or valuable, one of our for sure.
So it sounds like maybe we should modify that to propose something along the lines of what the coalition is doing, and then see if we get good feedback from local coalitions and others maybe. And maybe you start with limiting it to programs that they have everywhere, or like a home visiting program, but grow it to more family support programs over time if people can make it work. I don't know.
Mm-hmm.
Maybe there's something available, that idea of, for example, if you had a certain number of slots of available whatevers, whether it be funding or some kind of program, being able to push that out to the relevant communities and then track how quickly those things get filled up might be, first of all, you're measuring something, and you're also seeing, based on how quickly things fill up, it's almost like a job interview where 10,000 people are applying for a job. There's a lot of people that need jobs. So if in fact that data was available and could be pushed out by the relevant organizations and then disseminated, then you could track how quickly people respond to it, and that would be a measure of need, desire, and might attract future funding.
Mm-hmm.
Another one to think about from this would be, and I don't know if this is reported this way or gathered at the state level, but would be to be curious about the food bank network. There's a way that the food bank network is able to say anything about meeting the need or not meeting the need of food security. I don't know much about that system, but that would be.
Just to keep in mind that there's one food bank network, and then there are independent food banks.
So that, and the statewide isn't necessarily tightly tied to the locals?
No.
Yeah. Okay, so that probably takes that out of the scope of this for now. How about this number 15? We were sort of intrigued by this from, I think Illinois tracks this as one of their data points, is, an assumption that children fare better in communities that have an active early childhood coalition doing this work. And so that would be reflective of some capacity and commitment at the local level to do something. It's, right now I think we have like 22. Would this be something that you would see as a good proxy for growing interest in capacity around doing this work, or not? What's your thoughts?
I would be concerned about smaller rural counties because they don't always have the capacity to have people, a number of people engaged. There's not enough human resources to go around. How many are there? Do you know off the top of your head in the state?
We think about 20.
Okay.
Approximately.
And what does it hinge on to start or not start a new one? Is it likely to change anytime soon? Grow?
Well, I know that at least Patty Butler's Early Childhood Services Bureau had been looking at potential grants funding to help communities who are interested in creating them come up with the sort of support to do that. And I think through the Best Beginnings Advisory Council, there's still some support for the local coalitions, but not as much as maybe in the past when they had some infrastructure building dollars that were more available. But I think they're always trying from their perspective to increase the number statewide and look for funding and opportunities to do so.
Yeah, I guess my worry there would be that it's a construct of many different issues. So yes, lack of live bodies and also lack of funding from the state, not necessarily locally. I don't know if there is a connection. You said another state had used that, and it would be interesting to see what the exact connection that they make is.
So in the interest of time, which Sarah is so good at keeping track of with our 10 minutes left, how about if we pop to the last section here around risk factors? Do you want to sort of get that queued up, Sarah?
Yeah, it should be. Did it not move up for you?
Well, just like verbally, like how do you?
Oh, okay. So these are pretty. These are probably the most available out there. And Bala, you can certainly let me know where yours come from. But I know that 4 out of the 5 are in the Kids Count annual report, and the CPS foster care rate by county is slightly different because it doesn't use substantiations. But having worked in that system for quite some time, substantiations are. In Montana, they're based on an administrative rule that may or may not align with an actual child being in foster care. So they're not a proxy for foster care, but the number of children in foster care or receiving foster care services in counties, I know, is something that we had readily available. And then the others are things that are already collected and available. So these seem like everybody measures risk, right?
Yeah, the TANF, the SNAP, and the WIC are from DPHHS.
Okay.
We just get it from them. And the number 23 child poverty rate is from the American Community Survey again.
Okay.
And of those, I think that 20 and 21, and to a certain degree 22, are all subsets of 23.
Okay.
So really what we should do is look at eliminating child poverty, and we would all be good.
So in fact,
I'm writing that.
To that point, it seems like you've got a lot of different cells here with a lot of different information, but the social determinants of health certainly fall within the risk factors. I mean, many of the things fall within risk factors. So does this category of risk factors, I wonder how you were thinking this coordinates with the social determinants of health.
You froze, so someone else will have to answer that question. I heard only the very last part.
Am I frozen now?
No, I heard you, Gary.
Okay.
The question was like, how do we wrap this poverty piece into the social determinants of health?
Well, yeah, there's a lot of the social determinant of health issues are subsets of risks. Mm-hmm. They're risk factors. So I just wondered, since you have a category of risk factor and then a category of social determinants of health, how you sort of saw those two corresponding.
Well, maybe we just recategorize if we picked just the poverty one or something along those lines. I'm not sure we're that scientific about it at this point.
I struggle around that one because it feels so high level. you know?
Mm-hmm.
So
Is it actionable?
yeah, so I go back to,
Right.
Poverty,
From what? Oh, sorry.
poverty and
Go ahead.
education are measurable. I think you might have had them in there earlier.
Mhm.
Stress is a little bit harder to measure, but it could be something you could find out about by the coalitions interacting with the mothers.
Of those four poverty measures, I think all but three are hard to affect. They're great measures as to how kids are doing, but really, what are we going to do about it? There's so many things involved in the poverty rate that is beyond what we can do. From what I know of WIC participation, that might be something that can be moved locally. What I've learned is that there are barriers to getting WIC benefits that do not exist for SNAP and TANF, and those barriers make it harder for women to receive those services even though they want them, they apply for them, they qualify. They just cannot fulfill the requirements of meetings in person every so often in the middle of work hours. And so on a local level, I think that is something that can be addressed. The other ones, not so much.
Could one of the hope measures be, and you may have covered it earlier, but some employers actually provide benefits to mothers, maternal benefits or paid time off, other things like that. And I wonder if the employers, this would be a hope measure, that have these better policies in place that would seem like it would have a really positive impact on the mothers.
Do you know how that would be? Is that tracked anywhere?
I don't think so.
Well, I mean, there's a little involved, but we do work where we have web bots that go and read web pages of employers, and or sometimes you could just
Hey,
have,
Gary, that sounds really crazy. Web bots.
or you could just have people go to some of the major employers and look at their websites, and oftentimes they like to toot their horn if they have those enlightened types of policies.
I like the web
But,
bot.
but Montana is a state of small businesses that
Yeah, that's
more
true.
often than not don't have websites.
Mm-hmm. Well, but you have a place like Helena, and we have a big government employment and some large employers. So it depends on the community that you're in. But it's true that the bulk of the employers are small employers.
We're actually working on Kids Count as trying to get paid sick and medical and family leave up before the legislature again next session. So that could be that could be a state policy.
Mm-hmm.
That would
before
be
we know it. We're hoping.
Call us to help you.
Okay.
Yeah.
Hey, where did the one go about green space and parks and stuff like that?
Up here.
It was under the GIS further up.
Oh, okay. Sorry, I missed that.
Yeah, we didn't really talk too much about that, but this has to do with being able to map, using GIS tools to map a location. And you can map a lot of things. You can map where healthy food is available, or where you're in a food desert, where there are bike paths, where there are different things that are related directly or indirectly to health outcomes.
Is that something that we can get in Montana from?
Oh, yeah.
Okay. All right.
Really?
Well, yeah. There are characterizations of land. We have an application right now that tracks every parcel in the state. So plus there are other things like we use satellite measures that actually can tell you what is growing in particular areas, where there are forests, where there are parks, where there's urban areas, farmland, and all that. So there are a whole lot of things. And then you can look at the different businesses and organizations around and then pinpoint them, just like you would if you go to Google Maps, you'll see restaurants and different businesses that are highlighted.
So you have to go through the whole state, kind of square foot by square foot?
Well, actually, there's a lot of data that already has the latitude and longitude coordinates available for lots of data, and we use that extensively. Yeah, I got hung up on the how do you define a safe outdoor space and how do you define access? What does that entail, and how do you work that into a mapping feature? I would think that is something you're not going to find typically in a data set, and that would be more a community survey to determine whether an open space feels safe to the community or not. I don't know that you'd find that data anywhere easily.
So if I could stick my facilitator hat on with the couple more minutes that we have.
Right.
Is this all shut down in 2 minutes?
Well, I have someone waiting for me in 2 minutes, but you guys keep on. But
so, well, with JP and who else?
JP.
And JP and somebody that I don't know the number. Any other comments that any of you want to make about, something that's missing?
Sure.
Concerned about?
Dr. Pujol and I were just kind of jabbering back and forth. He is trying, but he seems to have failed to speak up, or able to get in. But he is questioning whether or not this is appropriate for Montana regarding rural settings, where just a most recent discussion that we have regarding parks, because some places don't have access, and in the same point, I guess, having lived in a rural area at some point in my life, sometimes my park is my outside, although it's not going to be in that, maybe labeling it in that way.
Sure.
So I'm not sure whether or not that could be a social determinant in some aspect, and whether or not that's even measurable.
Yeah.
Well,
before we get into that, just because we're almost done with this call, are there any other comments that you or Dr. Pujol have about the whole list in general, like any sort of?
Being an OBGYN, I can tell you on the upper part of it, I'm all about baby-friendly hospital. So you guys hit it on the nail. And my family is a family of nurses where they all work for Kaiser Permanente, so I know those work.
Nice.
So, as far as Dr. Pujol, I think he's okay for now.
Okay.
So my thought is that I'm going to save their comments and I'm going to mail them out to this group. And if you felt like you didn't have a chance to comment, just respond to me and I will add them to this document so that we have a compiling of everyone's comments, and then we can use that to prepare for our June meeting.
Great.
Will this be on Office 365, or you're going to email this to everyone as well?
I will email it to everyone because some people have had problems with Office 365.
Everyone has problems with Office 365.
I was going to say everyone.
That's true. Not my favorite.
Well, thank you all so much. Bree, do you want to close us out?
Well, I just really appreciate all of your guys' participation, willingness to help, and I look forward to just keep on moving along. We're moving at a nice pace. So
right.
Thanks for keeping up.
Questions you may hear from us before June. So.
Okay.
Thanks so much.
Thanks, everybody.
Thank you.
Thanks, everyone. All righty. Bye-bye.
All right.